of pandemic in Malaysia, we have two different perspectives here, one from the private sector and also one from the public sector. Matron Lai's hospital is hospital fully COVID, so she would have a very unique perspective on how to handle nurses during this pandemic. Maybe we can start off by sharing experiences about how training of nurses have been affected so far in these two hospitals during this time of pandemic. Matron Lai, do you want to start off?
Okay, Ken. Okay, good afternoon, everyone. Actually, before we place my nurses to the COVID area, we have COVID-19 training orientation for all the newcomers, including doctor, all the paramedics, and my nurses. So this training include the infection control and the PPE training. The infection control will tell them, will teach them how to do the donning and the doffing and everything, including all the infection control one related. And then another topic we will talk about the social distancing and the avoiding 3C at work and after work. And then what to do if they are feeling unwell. So after that, we will introduce all the newcomer about our psychiatric first aid. So if they got any stress, any doubt, they cannot cope with the COVID patient, they always can ring to my PFA counselor. So another, we will give the video show on the update of the COVID-19 now, and then we will give the orientation taught by our IT specialist regarding the epidemiology of COVID-19, and then the work rules and regulation. And when nurses are working in the ward, my matron, area matron, and the ward sister will constantly observe, is they doing the proper donning and doffing when they are working. Definitely, there is a mentoring program when they are in the ward. That is our preparation for the patient, for my nurses before they are placed in the COVID area.
And in the private sector, is there anything you'd like to share about?
Okay, Assalamualaikum and a very good afternoon to everybody. Actually, for us to face the COVID, actually COVID is a rapid issue of pandemic. So we need to prepare our nurses in order to face the cases, whether it's a curie, COVID or whatever. So almost the same, I think, because we also started with our awareness. We are quite lucky, we do have our infection control committee. We also do have infection control team to gear out, whereby all the infection control nurses and also infection controlling personnel to roll out the awareness series. So we run all the awareness and the training throughout our nurses, not only the nurses, we so-called healthcare workers involving any level, including from admission, discharge, the nurses, the lab, everything, all the healthcare personnel. So what we emphasize the same, we are emphasized on the hand hygiene, on the PPE, all the doffing, the donning, and other part that we also look at their competency, meaning that we already give them a series of awareness. We monitor and see their compliances, whether they are comply to what been taught earlier, and we also conducted a drill for those curie COVID. We make a code blue drill for those potentially or suspected COVID. So at least all the nurses, consultants, the healthcare workers are prepared and ready to receive all these type of cases.
Yeah. Right. I would like to add, if anyone wants to ask questions, you can just unmute your mic and feel free to do so. You can also do so in our chat box if you have any questions for our matrons or for me. So Matron Lai, you were saying something about all the methods that Matron Lai and Matron Norzana, all the methods that you use to implement all these awareness and training for all your staff nurses in terms of COVID preparation. Is there a method that you have to counter-check? To counter-check that done? Yeah. Is there? How do you audit what you do?
Okay.
Matron, I can answer, and then we can go to Matron Zana.
Okay.
Okay, what we do is actually in our local, we do have a committee for so-called COVID committee, which consists of our medical directors. We also consist of infection control chairman, infection control nurses, and few of the key people, including the CEOs and also purchasing. So in this particular, when we done the audit, for example, we get up our compliance officer and also infection control to run the audit throughout the healthcare workers to see whether are they complying to the PPE or to the practice, all the hand hygiene, all the distancing, and also we look at also the facilities. So all these, once we have an audit, we have the outcome and the report we will tabulate into the committee, and we identify where is the weakness for us to improve.
How frequent is this audit? How frequent is it done?
For hand hygiene, we are doing monthly, but for others, we are doing 3 monthly.
3 monthly. Okay.
Yeah. But for supplying, for example, PPE, they are reporting to us weekly.
Weekly, okay.
Yeah.
Tunai, in your hospital?
Almost the same like the private. So other than my infection control team, they will do a daily round for every ward, because I got quite big amount of infection control nurse in my hospital. Other than the infection control team, I got almost 47 of my nurses is infection control trained. So I think shouldn't be a big problem lah for they are checking daily for every ward. Other than that, the ward sister also play a very important role lah. So every ward, I will make sure every ward there is a sister working. If no sister working, the sister on night duty or off, other ward sister, the floating sister will cover, and also the area matron. So other than that, like the private side also, I got the Baka also, they got one team, they will just go and do round. They got the right to take the photo. Anybody is not compliant to the SOP, then we will give tindakan tata tertib lah.
Because as we all know, with this new norms of COVID, face mask, distancing, how many people in one on-call room or in pantry or in surau, there's even pakliling and guidelines that have been issued in a national level. So it's actually legally wrong if a person doesn't comply to these SOPs. Using My Sejahtera, all these new SOPs, I bet it's hard for them to get used to this new norm at any level, specialists, nurses, PPK even. So it must be quite mentally exhausting for your nurses as well.
Yeah.
What are the mental, you were saying about the stress test? Anyone has doubt or stress, they can liaise with your PFA.
Yes.
Regarding this, what has been the outcome, the feedback that you've gotten from your PFA in regards to their mental status of your nurses?
Usually, the task test we are doing is quite often. One thing. So the feedback, usually the psychology doctor, they will got the outcome. Usually they will come and see me personally. If got any special, sometimes they will call the patient, the person, my nurses. Or we got open door policy. So my nurses, they can always come in. If you want to see me, anytime they can come and join. And then my PFA office also, they always open. They can just walk in, want to see the counselor, also they can see the counselor.
What are the solutions that she has advised regarding how to reduce the amount of stress or exhaustion among nurses? Are there ways, scheduling wise or off days, or how do you manage this?
Usually like that. If there's stress in the area they are working, they say, saya tak boleh lah kerja tengah work ini. We will try our best to rotate her to other place. Sana rasa mana yang you rasa nak sesuai. Then we will let them, either they go to the other place or they will give them off. If they think, saya nak ambil cuti tanpa gaji sekejap boleh? Boleh, no problem.
Okay.
We will allow them to do lah. Usually we will change the environment, they will be quite happy already.
Okay, change of environment.
Change the environment.
Norzana, in the private sector, do you face this problem as well? Burnout?
In private sector, we are not really, because we are not COVID hospital as per se. But the thing is, for those we allocate them at the screening counter. We know they are stressed, they are very anxious. So what we do is we rotate them also. We don't let them, continuously run the same task at different. So we do a rotation basis. So hopefully with that, so far everybody quite okay, and they also been prepared mentally actually, because the most important, if we are really follow the PPE, the safety measures, everything actually is a safe cultures.
True. But there's also, because since we're talking about this new norm, we realized that we have changed a lot of policies. No visitors are allowed, right? Matron Lai, no visitors. Is the private sector also practicing this? No visitors?
Yeah, in private sectors, no, that I know during our visiting hours a little bit loosened compared to me, but during this pandemic, we strictly followed exactly what the MOH guideline. So we display a signage. We also give in advance throughout our website everything about the visitors guideline. So far, we don't have faced any problem, because I think it's a national issue and awareness being given to everybody in advance. So we get a good cooperation from the community.
True. Anyone have any questions for any of our matrons or myself thus far? Please feel free. Okay, so in continuation, also regarding this new norm, because we're limiting the numbers of people we're allowing inside in order to reduce the risk of transmission or the risk of the disease, there's also a change where the students aren't allowed to come and learn from the hospital, maybe private or public. Can you give your thoughts on this? And what do you think about the amount of student nurses coming in?
So, doctor, for my hospital, we are not allowed the basic student nurse to come over. We are not allowed at all, because they are basic. They don't know anything about the patient care. We only got one time, there is a second wave. Suddenly we got so many patients. So we are allowed the post-basic student come over here and help us. That means at least they are a qualified nurses. They are qualified nurses. So they come here, we just like all the newcomer, we are giving them a training. Even we train quite many of them for army to prepare the MAIS. We are training quite a lot of them for the MAIS also.
Oh, okay. So you're still allowing post-basic nurse to come and help at certain disciplines and certain departments. How about in the private sector?
For private hospital, since our colleges, KPJUC, actually we abide with the Ministry of Higher Education. I think they circulated a memo saying that all the students in higher institution, they should have been revoked from their posting. So we are not allowing any of the students to be around. So we have to return back to the college, because I think they need to go for online studies. So there is no, for the time being, during the pandemic, there is no student available in the ward.
What do you think about the amount of training that student nurses have right now in the curriculum now that's being trained in terms of pandemic management? Is there enough? Should you add more? Do you think this is something that we should include for future purposes? And what topics do you think should be included in terms of in the nurses level that they should be taught? Maybe Norzana can answer first.
Yeah. Okay, for me, if you ask me regards on the student syllabus, the most important is about the community disease and also the contagious. And should more be emphasized on during the type of the contamination method, and also how to be tackled. I mean, the type of PPE, the usage, the guidelines, everything. Because right now, yes, those days we are not really have exposure much, but now with the current SARS, at MERS-CoV, and now coming is a COVID, I think this is the area that we really need to be emphasized, especially on the infection control.
Agree. Matron Lai, do you want to add to that?
I think for the student nurse, because the basic one, they must check up first for the basic one. If not, the basic also cannot handle for the infection disease. I think it's quite risky if we take them in. But if they are already qualified, I think shouldn't be a problem since we are got in-house training for them, especially the mentoring program. I got quite a few of new nurses newly qualified. We will send them to the infection disease ward. They are well trained also. Makanya we are training under mentoring program until we are make sure they are really can handle after maybe 3 months or 6 months. Then only we pass them to take care of the infection disease patient. Like MERS COVID is quite common in my work, in my this one, because we are IT hospital kan, Sungai Buloh.
So what do you think are what is the outcome or the gist of this whole pandemic that we can learn from? What are the challenges that the nurses are facing the most, do you think, that your nurses are complaining about the most in terms of this pandemic treatment?
My nurses.
Yeah.
Stress.
Stress in
stress in donning and doffing the PPE. Yeah. From the very beginning, because we are not so well known about the disease. My nurse, every time they go in the patient, they attend the patient, they come out, they have to go and mandi bath. So to meet them is very tired. Sometimes they come and say, Matron, I'm so tired today, I sudah mandi 5 kali. But now, because we are know better about the disease, that means we doesn't need, from the very beginning, we put the norm for the nurses for PUI patient is 1:1. The COVID positive is 1:2. You see the burden is there. Now it's okay because we got the experience from the 2 wave already. Now I put a very minimal nurses to look after the patient. So my nurses they are trained already, consider 100% all trained. Now they got no complaint anymore. And
maybe you can share about what is the role of the nurses that take care of these COVID positive or PUS patients. What do they do? How does it? What is a day in the roster look like?
Oh,
is that okay to share?
Yeah. Because now we are using the Muse observation. You heard about that Muse observation. So with the Muse observation, we will score them got the scoring. Usually for the 1 shift, my nurses only go inside once to attend, once to take the observation. That means they do everything 1 shot, serve diet, observation. They go in once.
Okay.
Unless the patient got anything they want to communicate with my nurses, we are using the phone. Okay. We are using the phone. So anything, unless necessarily we will go in another time. If not, we will just once we go inside. But we can communicate via the phone.
How about the one in a more critical setting like ICU?
Or ICU. ICU is more often because they are wearing N95. Sometimes they go inside. Once they go inside, I think they have to stand more than 2 hours. Sometimes up to 4 hours. 1 shift is 7 hours. If they go in already 4 hours, I think everything should be done within the 4 hours. The ICU nurse is really very tired. But ICU nurse, if I got enough nurse, I will put 2 nurses for 1 patient. If I got enough. If no, we have to share up. 2 patients, 3 nurses for 2 patients.
3 nurses.
They don't need to go in, out so often. They need anything, minta tolong outside people to bring in. So the nurse will stay inside maybe 2 hours to do the sponging, to do the turning, to do the tracing. 1 shot they're doing in the 2 to 4 hours. See how's the procedure. If they got hemodialysis, definitely they have to stay 4 hours inside with the patient. If not, I think 2 hours can settle everything. Suction everything, they do it 1 shot.
It's quite mentally stressful, I can imagine.
Yes. It's very stressful for my ICU nurses.
So I'll direct this question to Norzana. So let's just say one of your healthcare worker, your nurses, anyone below you, is developing symptoms. Not necessary contact with COVID positive. As you know, Norzana is from KPG Kajang, so Kajang is now a red zone. So just because it's already in the community, is there any fear? Are people opting to go for, what is the hospital policy, or how do you go about this when patients when healthcare workers have symptoms?
Okay, we do have certain policy for the nurse, the staff. Yeah, those are exposed for the or suspected POI or everything, and they come up with the symptom. We will send them for our MO to have us assess. So once our MO seen the staff well-being, then they will fill up the form. So from there, either it's just from the symptom, everything, the MO will decide whether it need to be the COVID test, or just need for the home assessment. So this one also we will be shared during our COVID committee discussion too. Yeah, so we do have, so those, for example, we are suspected because it's maybe he look after the patient positive. We also provide, if they worried about their family, they want to expose their family, we offer them to stay in our hospital, whereby we allocate them in one room. We provide, so at least they are not exposed or bring it back to the families. We support throughout the way. So far, about 2 staff we offer them if they don't want to be in the house.
Oh, so you offer a room in KPJ Kajang? Oh, that's very nice of you.
Until their result back. If their result negative for twice, then only we allow them to go home.
So 2 swabs will be taken for these healthcare workers?
Yeah, but the choice is them. We give it to them. We are not forced them to be stay throughout the until the result back. Is if they worry, for example, they have a small kids, they have a high risk at home, so they say that they were not really confident to stay at home. They don't think so they can isolate themselves in their house. We offer them.
Okay, and
support that can give to them.
Yeah, that's very good support. Thank you. That's very helpful. And Buloh, how about your workers who are symptomatic?
My nurses, because they are already taught, if they are unwell, usually they won't come to work. They will give a call. They will give a call to the sister in the ward. Then the sister will advise her go and call the OSHA. The OSHA will tell them what to do. If they need to swab, they will go to my PUI center. They swab there, then they will get the Sula quarantine. Then they will stay at home. Yeah. If those who got symptoms, usually we will admit them. If PUI got symptoms, usually we will admit them. If they want to admit, if they think they are safe, stay alone at home, I think. But symptoms usually we admit. Because fever, usually we will admit them.
But because we know when mentally, when someone's very worried, the symptoms of fever and cough can just come. So what I see in this hospital as well, when there's someone detected positive, a lot of staff, because of the paranoia or their worry, everyone becomes like, oh, I have fever as well, or I have cough as well. And what I see is that a number of staff will be away because of quarantine.
Yeah.
Does this happen in your hospital? And how do you cope with the amount of staff missing? How do you compensate the numbers? Maybe Matron Lai can answer first.
If you mean the outbreak, yeah.
Because when there's someone positive or someone has symptoms,
yes, someone positive, we have to the OSHA, they were tracing, yeah. They were tracing. Those who are close contact one, we will isolate them, yeah. We isolate them. Like recently, we got 2 staff nurse positive, but we will see the contact. But lucky thing, because we are quite everybody follow the norm, yeah. Like they all makan sama-sama, not very close on contact. So not very big amount. Only few of them gonna quarantine, only 5 of them gonna quarantine. So we still can cover. We still can cover the workload for that ward.
It's still manageable. Has this happened in your hospital, Matron Zana?
We do have those exposed, for example, and then when they heard that, oh, this patient turned out to be positive, we are sent off to the Buloh, and like what the doctor says, I got a sore throat, I got dry cough, all these sort of symptoms coming out. But whatever we did is, what we do is we will call and find out first. Normally we will ask them a few questions. One, whether they are wearing PPE, a complete PPE at that current time. Second, the duration when they're exposed to the suspect, so-called. The third one, whether how long the duration and what is the distance. And the last one, whether they are practice hand hygiene. If this fulfill, then we will do the monitoring temperature for the 10 days. or for 14 days. So if you have in between, there is a rise of fever, whatever thing, then only we'll present it to our infection control chairman, whether the needs to have tests to be conducted.
So because I realized that, and I think this is a reminder to everyone, as long as you follow the proper SOP, mask, hygiene, distancing, even though the patient is positive, the risk for you getting infected, as I noticed with staff in my hospital, the chain can be broken if you are following proper SOP, no matter how close you are, or you know.
Yeah.
So I think
That's the most important. That's why normally this is 5 questions that we will ask them. The minute they say, oh, I'm dealing with this patient yesterday, for example, the patient came to us, right, this, we will ask this question. Are you wearing a complete PPE? Are you wearing the mask, surgical mask or N95 mask, whether you have a face shield, glove, everything. Secondly, the duration, whether you are communicating within 50 minutes or more than 50 minutes exposure. Then the duration, for example, the distance. Are you too close? Are you this one? Are you wearing all the glove, everything? And of course, the rest of the day, we ask you after you finish once procedure, whatever thing, do you practice hand hygiene? And the last days of, we also give them, encourage them before they go home, take a bath first. We provide all the facilities with the warm water, everything, and change their uniform before they go home. So far, we have manageable, none of our staff, alhamdulillah, so far.
I was wondering also, because I think there's one clause in one of the guidelines, I think the latest guidelines, about ensuring that your healthcare workers who are at risk, so obese or with chronic disease like diabetes, pregnant staff and stuff, to not work in these areas. I guess it's easier for certain hospitals who don't treat COVID, but like in Sungai Buloh, or in private, where you can't mobilize them elsewhere, I guess that's difficult because of this guidelines. Can you share your thoughts? Maybe Major and Lai can share your thoughts about these staff members.
Yeah, for the second wave, in my hospital Sungai Buloh, I think I almost got 150 nurses pregnant with the comorbid. No, I have to send them out to other hospital like Selayang, Shah Alam, Klang, and any hospital they want to choose. Then I just send them there. I got no choice. That's why in the second wave, the KKM and the state matron, they support quite many of the nurses from other hospital and the other state also, like Kelantan, Kedah, they send nurses to come and help me out because too many of them gonna go to other hospital. For this time, not that many, almost around 100 of them. But this time, majority of our nurses, I send them to the hospital Shah Alam because we opened the neurosurgery service there. Because you know, hospital is the what we call is the trauma, is the neuro center also. So the neuros, they need to continue their service. So we open 10 bed in the hospital Shah Alam. So all my pregnant staff, I sent over there. Not all lah. Only maybe around 12 to 20 like that, I send them. The rest of my nurses, I will put them in the PMU unit. I only left one ward, non-COVID here. So I put some of them is inside the non-COVID ward, only one ward only. And also my coastal ward, I got 60 katil there. So I also put all my pregnant staff there. So all divide, that means it's quite okay lah. This time I never ask for help because I use the minimum staffing. I don't want them too many staff. If they're too many, they will kumpul together, then they will get infected. Now every ward, every shift, I only 3 staff to work for 28 patients, 3 nurses to work. So they got no time.
Who is pregnant and she doesn't mind to work in a COVID risk area, would you still allow it?
No, we are not allowed. And those who come back from the confinement leave, they are breastfeeding the baby, the baby, we also not around. We will send them out also. Unless they say, matron tak nak pergi lah. They want to take unpaid leave also, I around them to have their unpaid leave. Because it's risky for them, no. It's very high risk for them. Our IT specialist also not encourage them to work, especially the pregnant pregnant lady to work in the COVID ward. She also feel this, I think this field they also quite often just matron saya pregnant lah. So I got no choice, I have to send them out also.
How about in the private hospital, Norzana?
For private hospital, of course, the same. The minute we have to allocate our staff for screening for PUI ward, we identify who are at risk, who are identified under risk category. Those are diabetes, those are obese, pregnant. We allocate them per side. The only thing we are a bit lucky, because not to say so-called lucky, but what to say is during the MCO, our BOR numbers are reduced a little bit. So with this, I can have a deployed pool of staff nurses. Those are not high risk area to allocate all this at screening and also at PUI ward. So we make sure that our PUI staff are free from pregnant, free from high so-called morbidity, comorbid.
So I guess it's part of the rules. We just have to try to do the best that we can with the numbers given.
Yeah, true.
Is there any stigma? I think because is there anyone positive so far? Any staff member that's positive in your hospital, Norzana?
So far, no. Yeah.
In your hospital, I know there are a few that are positive. Is there any stigma of them coming back to work after being discharged from being positive?
For Sungai Buloh, no stigma lah. Everybody understand what is COVID if got stigma.
I think because
community.
It's very, I think Hospital Sungai Buloh is a very well versed regarding this illness, where certain hospitals who at Kajang, we're very unfortunate that we are also have to be well versed because we are a red zone for a very long time. But other hospitals, because they don't have that much exposure, the one factor that really affects most of the staff is the mental aspect of it, the fear of COVID. And I think that's the hardest issue to tackle. So I'm glad to hear that both hospitals are doing very well in terms of that.
Okay. To say that about stigma, it's not really, I could say stigma, but more on perception. So for example, I do receive about 2 resignations from the staff the minute we said, I allocate you in the PUI ward. Okay, so basically the nurses actually are prepared, but I mean the next or the family members are actually not really confident enough or perception that PUI ward is receiving all this COVID. So when the one, of course, he not turn up, he's also absconded because the one do it, we can't do anything much. But the other one, after we sit down together, explain all these things. So far he quite happy working in the PUI ward. We don't face all others.
Because in my hospital, I think we're also half-half. We don't treat COVID, but we see a lot of suspected patients. So people just have this fear regarding it. Any questions from the floor? I think we can open for about 2-3 minutes. Any questions from all the participants? I think this is a good opportunity. We have 2 really well-versed matrons at our disposal. Questions?
Question. Ada soalan.
Ada soalan ke?
Tak nampak ada pun.
Saya tengok. No. You can if you're very shy to voice it out, you can put it in our chat box. Also, I'll read it, no problem. There's no wrong questions and definitely no wrong answers. Also, regarding compensation, because I know the ministry has allocated some funds in terms of allowances and leaves for those who are taking care of COVID positive or those who are highly suspicious. Is there something similar that the private sector does in terms of this?
Yeah, for private, we do have our talent management, also called HR. They come up with a memo about what is from the government. We are following what is the government compensate, even the COVID allowance.
Oh, so the private sector is also providing some compensation. That's big. In terms of new methods of management, because I know we are forced to go into more high-tech usage of machinery to manage COVID patients in terms of teleconferencing like this or telemedicine? Is there anything that's implemented for your nurses this way? Any new high-tech machines that you can share that you're using in terms of reducing the amount of transmission of COVID for your nurses in your hospital?
For Sungai Buloh, like the meeting, usually we will use the virtual meeting like this, or this one, the CME also, they will open the link and they just sit down at the seat at the anywhere they got computer, they can sit down and listen for it. For this high technology, we got UV light, yeah. For the they got the rostering to bring the UV light to every ward, especially those tempat berkumpul, the nurses like the pantry, like the sulau. Usually they will put the UV light. That is the procedure for it.
Oh, so the UV light is used as a method of decontaminating.
Decontaminated the germs in the usually for the clean area.
Anything in the private sector that's different than anything?
We are not using actually on the UV light, but we're more on the aerosol machine that we put the disinfectant, and it will be using to say the solution, then it convert to become the aerosol. It's some sort like air ionizer, but the content actually more on the disinfectant. So this machine will be on in the particular area, especially in the crowd area, once, for example, during the break time. So once when the lunch time or everything, so we will initiate this machine to disinfect the environment. But we are not using the UV light like Sungai Buloh did.
I think that one is also the first time I've heard about the UV light usage. Something we share with other hospitals. I think that's a very good. So far, we're just using that spray, the spray to the detergent. We're using detergent.
Yes. For the waiting area, the seat, everything. Yes, the housekeeping people will come and wipe and disinfect the area. But for the environment, we are using the machine that generate the aerosol from the disinfectant. It convert into aerosol, and it can be some sort like decontaminate the environment. So less on human touch on that.
What do you think is the biggest change in terms of management for nurses because of COVID? What is the biggest change, and how have you tackled that? From everything that we've implemented, what do you think is the biggest one? That is number one priority. Maybe Matron I can answer first.
The bigger change in what aspect you want me to talk
about?
So
anything from everything that we've done for COVID, what do you think is the biggest impact that you think nurses have to be considered of from everything? Just SOPs or awareness?
Infection control, infection control awareness. Already improved a lot, because before they are not so bothered because they are working in the normal work. They doesn't need to wear the full PPE or this thing. So because of this COVID, everybody had to train how to do the donning and doffing. So they had to 100% train as a COVID nurses. One thing. Second thing, the norm for the nurses, norm for nurses and patients. So for COVID patient, now we are putting almost go back to the normal norm, not like before. The norm for the PUI patient, we put 1-to-1. Now no, we doesn't need. And then the third thing, the stress for them is the mobilization, because let's say before that the one ward they got 25 nurses. Because of this COVID, I doesn't need so many nurses in that ward. So I have to mobilize them out from the ward and go to the other ward. Because the capacity beds from Hospital Sungai Buloh from the before the COVID time is around 900. Now we are increased to 1,800, almost double of it. So the nurses also, we still using the same amount of nurses. So I think that is the stress and big change there.
So the same amount of numbers of nurses, but
Yes.
increasing workload in terms
Yes,
of...
it's a big capacity of the hospital. It's increasing, same amount of the nurses. You must remember another 100 already minus to the other hospital. Cannot work for COVID one.
And how about in private sector? What do you think is the big so far?
A big change of nurses. Of course, there is a few in the guideline also involved. Of course, in the infection control practice, like Metronline says about the PPE, about the hand hygiene, especially we can see the compliance rate for hand hygiene actually is increased. Not only nurses, it's all the healthcare workers, everybody very conscious now. Everybody also start to look at your hand, whether you are touching here and you have washed your hand, whatever thing. But the secondly about the assessment of the patient. The nurses are more diligent, diligent in assess the patient, in have a history taking, especially they want to know from area, because like Dr. say, Kajang is a red zone. We are not more focused on the Sabah, we are more focused on the cluster area we generated. So the girl are more actually conscious on that. And others also, because we make a rule, certain rules, for example, patient going for OT, they must have a COVID result. So all this they really need take into the account, whether the patient have been done all the COVID and the result is been back. The third, there are a few of guideline or policy we have also changed. For example, patient upon the doctors wanted to see or the nurses want to see the patient visit or do round, we make sure the patient also put on a mask. On top. Not only the healthcare workers, the patient itself also put on a mask. The same goes also, we make sure that patient when goes to operation theatre, also of course with the COVID result back, and also we also prepare a dedicated for those suspected. For example, we do antigen for those emergency cases, because antigen we back result back a bit early compared to PCR, but these cases will be allocated in the special OR. You don't mix with others PCR negative. So there is definitely a certain SOP have been changed according to the new norms in order for us to cater not only for the patient, we also for the healthcare safety.
Because I would like to share from in my hospital, where I see those in high risk areas where people are actually treating those who are suspected or sorry patients. The risk of COVID transmission, we have no cases of everyone being positive in these areas because everyone is tengah jaga betul-betul lah SOP. But once you go in areas macam pantry, tempat makan, surau, actually most of our staff who have been positive are have conceived COVID from these areas where people tak jaga betul-betul SOP. So if SOP is terjaga everywhere, I think we will break the chain even faster. So SOP is probably like the biggest issue from here. I will also like to share one other experience. I think this is from H-Star Klang, who similar to KPJ Norzana. They the patients all will wear masks. All the patients wear masks, but they took it one step further, where any respiratory infectious patients will wear a specific color mask, and normal patients will wear a different color mask. So I think they use orange and purple, or orange and green, I'm not too sure the color. And orange mask means respiratory infectious. So if you see a patient with an orange mask and you were in the vicinity, you know to be on higher alert, to step, one step further back from this patient. So I think that's a good,
yeah,
simple but very effective.
Yes, true.
Is there any tips and tricks like this that your hospital has implemented that you can share? Maybe we can implement on our hospitals.
For us, those actually outpatient, those if let's say the upon they want to enter, they have to go through the screen counter. The minute we notice whether they do have a fever or URTI, we straight away allocate them to the tent. We don't allow them even to go to the outpatient clinic, and the consultant will come down for their clinic and review the patient at the tent itself.
Okay.
So we straight away, we safeguard from the entrance itself. We're not allowing, because we don't want the patient being waited, spend a time waited out of the doctor's clinic with all the fevers, everything. So the minute we knew that the patient have a fever or URTI symptom, we allocate them under the tent outside, and we just notify to the consultant, certain consultant, the consultant itself will come down.
Okay. And is there any new tips and tricks that you guys implement to prevent spread? Anything different or something you're proud of that you can?
For Sungai Buloh, we got the staggered time for the patient coming from the clinic. The staggered time, one thing. And then they got this one, the link. They got one special link for the IT. They make a one special link. They will come and scan. Then after they scan already, then they can wait in their car. When it's their turn come up, then they will message the patient. The patient only 15 minutes before that, they only can come inside the doctor's area waiting room. Then only they can come in. If not, they have to go somewhere else, not in the waiting area like before. Before we are waiting area so full of patients. Now no more. We got a staging time for them to come.
Or outside, yeah.
So for ours, except on dialysis, we have a dedicated team to look after of the dedicated patient based on their rostering. For example, the patient came on Monday, Wednesday, and Friday. Only the same dedicated team actually look after them. Because we don't want exposure, because if let's say one case happened and we can conclude that most will be affected, but if let's say anything happened, only this dedicated team is affected. So that is what we do on dialysis.
That's good. Different, we kind of reduce the amount of transmission.
Yes, we control that.
I know it's really taxing for all our staff, no matter what level, to kind of manage COVID. Other than monetary compensation, other than the allowance that we're given, is there any other form of appreciation that you give to these staff? Any other ways that you can compensate them that you think to make them feel more at ease? Matron Zana can answer first.
Yeah, for the first COVID, when the first MCO end up, we do celebrate them, we do appreciate, and we do have a special function for them to celebrate all the frontliners. But for the time being, let it cool first. Then only we will do another appreciation on them. That's all from us.
Which I think you recently in June, I think it went from fully COVID to hybrid COVID hospital. Was there anything that you guys conducted for these frontliners for the whole hospital? Or not yet? The war is not over yet, is it? Tak habis lagi.
We all sempat bought from COVID to hybrid, only I think less than 2 months. Then we quickly go back to the COVID. So it's make us is quite tired to re-prepare the work again.
I understand what you mean, because when Hospital Sungai Buloh, we have one question here from Mary Patricia. Let me see. One question.
What is the?
How do I view it?
What's the question?
Okay, the question is.
Good. Do you want me to read it? I'll read the question. Good evening. I would like to know from Matron Lai, there was a time in the beginning during the second wave, we had lack of PPEs, especially in mask, in precise N95. Did Sungai Buloh also have the same issue? If yes, how was it managed?
Yes. For the second wave, yes, we got kekurangan N95. But then we tetapkan who around to use the N95, who's supposed to use the N95. Yeah, usually the priority we give to the patient, the nurses working in the ICU. the nurses in the normal ward, actually the 3-player mask should be is enough. Is enough for them. So then for that time, we also recommended reuse N95. So the infection control will give training to all the nurses, especially the ICU nurses, how to do how they can do to reuse the N95 mask. Then at the same time, the pharmacy will try their best to get the N95 lah. We got the CSR sponsorship from the China emphasizes. They give me also quite a lot lah for the N95 mask.
I would like also to share in my hospital, what we did was there was also N99 masks that was available that we had just a limited number. I think we gave it to just individuals and they could use these masks for 2 weeks. So that reduced the burden quite a lot. For 2 weeks you could use. Also, as an alternative, a 3-ply mask with a face shield is also serves roughly the same purpose. On a filtration N95 and a 3-ply mask is the similar filtration, just in terms of fit is where they kind of there's a disparity. So to kind of compensate that disparity, what we did was a 3-ply mask is also fine, but make sure that you use a face shield over as a double layer of protection. I know there was shortages everywhere where prices of masks skyrocketed and was also unavailable for a short duration.
We are looking at any sources, whatever to get the N95. We are not only stick to one suppliers. We are try level best to look wherever things. So the same, once we do have so-called enough supply, we also not been using it easily. We start to restrict the area that are more needed to use. For example, A&E, because they are facing their frontliners. Actually, we do not know their status, and also ICU, and we also need to prepare for the PUI ward also, because sometimes maybe those are suspected in PUI ward actually is a positive one. So we start to stringent the usage to those are more needed areas.
I would like to also add to that, just because I had an experience with some of the purchases that we had with N95, where they are N95 or KN95, but in view of the companies that were not very well known, that we send all N95, one sample from each batch to go for fit test. And even though they are mass produced and widely used, certain N95 mask does not pass the fit test. So more so than quantity, quality is also important in cases like this, because you think you're protected, but the N95 mask cannot be used as an N95 mask, is where we face some problems during the second wave. Any more questions? Please feel free. I think we covered most of the topics with a little tangent here and there, more interesting cases. Is there anything, I'll leave it open if you want to share interesting cases in your hospital maybe, or how we can learn from it. So since you went through it, maybe we can learn from it. Maybe Matron La, you want to share something interesting that you can think of? Nothing, anything you can think of.
But sad story lah, yeah. Usually the patient, if they are intubated, before they're intubated, no family is critically ill patient. No family was around to stay with them. So if they are, that means that if they are pass away on that day, pass away, the family member also cannot come and visit them. So they only can go to the mortuary, wait in the mortuary, and then they straight away go to the burial in the grave. So tak sempat nak jumpa for the last. Tapi kalau nak tengok muka itu, ya, we are around.
So those who are COVID positive, when they pass away, can you explain a bit on the procedure on that, on the flow roughly?
Okay, usually macam ni, kalau dia pass away, for the Malay, usually they pass away, my doctor will inform the family member. So we allow 2 of them to come, 2 family member only dibenarkan datang. Then they cannot come to the ICU. We will arahkan they all go to the forensic, waiting in the forensic. So they will go to the forensic waiting and then sign all the document. So for Malay, we allow them to go inside the room. Then we play pop player lah with our ustad and our medical team inside the room. But the family member need to wear the full PPE and go inside. But they cannot touch the body. They are not allowed to touch the body. So after prayer, they are special kan, they will zip and then they will hantar ke kuku and then they will ke bumi there and there lah. For the non-Muslim also the same. Usually we are not allowed them to go inside also. They can see from outside of the window. There is the media kan, they see from outside. We just open a little bit to see the face. And then we all will nasihatkan untuk dibakar. Yeah. Then they will prepare lah. Either they can go to the private to bakar the body, or we will arrange the body to go the special place to bakar, and then they will bring back the abu and then they will play at home. So all the players like we all do before, the normal one, they cannot do. They cannot bring back the body to the house. So straight away pergi bakar. So that is quite sad, yeah? Quite sedih kan? Sedih. Cannot see, cannot hold.
I think that's also one of the bigger changes due to this COVID-19.
Yes, yes. I make sure don't get the COVID-19. You don't die because of COVID-19.
True. There's also certain patients who come in. I don't know if Norzana has this experience as well. They're brought in dead, and you don't know their history. You don't know, their status. What happens with patients like this?
Okay, for us, those are BID, so come to our hospital. We also do the COVID test, and we will keep at the holding bay until our COVID test result back. Then only we release the body. So because we won't know whether they are due to COVID or not. So we better get prepared. So normally this case, we definitely do this PCR or COVID antigen first. Until the result back, then only we release to the family members.
Similar to I think public hospitals, yeah. And also we see a wide usage of RTK antigen, which is quicker. We get results quicker, maybe for pre-op assessment and stuff, and also use of PCR, RT-PCR. But do you use any antibody, the RTK antibody in your facilities? Maybe matron line, do you use RTK antibody?
RTK antibody.
At the moment in Hospital Kajang, we don't use at all. We don't use.
I'm not so sure RTK antibody.
I think
so
we
far
don't.
I never heard the PCR, RTK PCR. Usually we are wait for the PCR result. Sometimes it takes 24 more than 2 days, no?
I think it depends on the volume load. So during the June until August, the volume was very low. So I think within 24 hours, we got the results. But now, because of the very big volume load, up to 48 hours, then we get the results.
But for healthcare worker, we will try to trace the result within 24 hours.
Yeah.
But easy for us to tracing.
Using the system.
Yeah.
I think any other questions? I think we covered a lot of topics, more than required for sure. Thank you to all participants. I'll wait for a few minutes if anyone has any other questions. If not, I think we can call it a day, right? I think it's okay. Anyone? Let me see. Any topics that you would like us to talk about or cover or share experiences with?
Okay, if there's any questions, I don't think there is. Okay, well, let's just end this topic session. Thank you so much, Dr. Amalina, Matron Lai, and Matron Zana. Thank you so much, everyone, for attending this seminar. We'll see you soon. Thank you.
Bye.
Thank you. Orang lain, mama lain. Yang tu you punya kawan. Nah, ni kawan you. He wants to say hello to you. Tunjuk dah muka. Dah tunjuk dia nampak kan?
Hi.
Hai. Sherry macam mana Sherry? Aku tak tahu. Tadi yang IT cakap tu dia tadi. Tidak kita dapat sebelah. Iya kah?